So Ira, I'm from Oklahoma. I went to medical school at WashU, and then I became an ENT resident and did my general surgery residency at Jewish Hospital, where I met my senior resident, Ira Codner. And I became fascinated with general surgery, mainly because of watching you and our teacher, Stan London, and I wanted to go into general surgery because you were extolling the virtues of general surgery. And I was able to switch out of ENT, was lucky enough to get a general surgery residency, and then you went to the Cleveland Clinic and came back and were extolling the virtues of colon and rectal surgery. And as it happened, we really needed colon and rectal surgery at Jewish Hospital then. It was a niche missing in St. Louis. And as part of my requirement to get staff privileges again, if I took a colorectal surgery residency, I would be able to come back and join the practice. If I stayed as a general surgeon, that couldn't. So that was an incentive, and you were establishing a practice there. And I was lucky enough to be able to go to the Cleveland Clinic, get my credentials in colon and rectal surgery, come back and join you in private practice in St. Louis. And eventually, we joined the full-time faculty at WashU, and you established the program of colorectal surgery at Jewish Hospital. And so that's how I happened to come to colorectal surgery. I had no ideas of my own. All of my ideas were yours.
So we know that a lot of our trainees change their mind from what they started out, and many of them end up going into colon and rectal surgery. What was your discussion like with the head of ENT when you expressed your desire to change?
It wasn't good. It wasn't a good discussion. In fact, I quit 2 years. At that time, it was a 2-year general surgery residence you had to have, and Dr. Ogura was a world-renowned ENT otolaryngologist, and I was in the ENT program. And after the first year, I decided that I wanted to go into general surgery and went over and talked to Dr. Ogura. And he convinced me again that ENT was the best and persuaded me to stay for another year. But about 3 months into the next year, I decided again that I wanted to go into general surgery and called Dr. Ogura and told him that I really couldn't do it. I wanted to stay into general surgery. And that conversation was less satisfactory. It lasted about 4 seconds until he hung the phone up and I didn't hear from him again. So that ended my ENT career.
What do you think, Bob, as you look back and maybe forward, are the main things that you've accomplished in your practice, your time as a colon and rectal surgeon?
Well, I don't know that I've accomplished much. I think, you know, we've all done a lot of good. We've advanced patient care. We've taken care of patients doing operations that we never thought that we would be able to do, to the point that it's become routine and mundane, and we don't really appreciate the fact, I think, of what we're able to do for patients. We never thought that we could do what we do now, and we do it to the extent that it's become routinized to us, and I think we lose the value of what we do, which is a sign of a good profession, signs of good surgeons, that you don't get so taken away with yourself that you can't back away and stop doing this.
Do you think the specialty is changing? And if so, is it getting better or is it getting worse?
Oh, the specialty is changing and it's getting better. And it's, the operations are getting more sophisticated. The morbidity and mortality, I think, is decreasing. It's going to be really incumbent upon us to make sure that we don't get caught up in the reimbursement problem, that we think of our patients first, because our profession is getting, the advancement of our profession is getting such that we are actually able to eradicate rectal cancer in a significant number of patients now without operating on them. And the real patient's advocate has to be the colorectal surgeon, decide that it is against our financial interest not to operate on these patients. It's the duty of every professional to try to put his profession out of business. And we're coming to that, as to the elimination of proctectomy for rectal cancer, to put ourselves out of business so that we no longer do this operation. And someday in the future, maybe not in our time, but maybe in our grandchildren's time, sometime in the future, they're going to control this by a gene identified, take a pill, and our business, we will be looked upon as barbarians of the past.
What are some of the things you think are happening for the worse? What are some of the pitfalls ahead, or the pitfalls that we're already into?
Yeah, I think the things that have happened for the worse are the outside forces taking care of the training of surgeons, the elimination of professionalism in our practice because of the stringent requirements for overseeing residents' work hours. They've broken the bond between the residents' feeling of obligation to the patient to see the patient through this, because a resident he has to follow his work hours, and if he's in the middle of an operation when his 8-hour day is over, he leaves and another resident comes in and takes his place, and there is no feeling of regret about this, and the bonds of professionalism have been broken by that. I think the bonds of professionalism will be reestablished at some time, but this is very bad for surgery. It's bad for our profession. Surgeons know how to train surgeons. The government doesn't know how to train surgeons. And the damage that this has been done to our profession is yet to be revealed. I know from giving the board exams over periods of years that the candidate for certification that we examine now is not as qualified as the person that we examined 7 years ago. And that has to do with the decreased amount of work that the surgeons put in. He doesn't take the night call, he or she doesn't take the night call that they did when decisions are made, autonomy is made, and they haven't had the valuable learning experience because of these changes in work rules. And I think that's been devastating to our profession. And it's going to take us some time to recover from that.
You seem to express a ray of hope. What do you think is going to change that's going to get us out of this?
Well, I don't know what's going to change. For some reason, for intents and purposes, is that train has left the station, and we're not going to be able to take it back completely. But this is America, and the hardest working people are going to be able to continue to work hard. They may circumvent the rules, and they may study more than they should when the work hours prohibit them from being in the hospital. But the best residents are going to continue to do the best work, and this is a highly competitive field. And when it becomes obvious to the co-residents how their residents who have worked so hard, who have put in more than their 80 hours, are achieving and reaching higher status, getting better results than they are, they're going to develop these attributes of our professionalism again. You can't stop people from working. You can't stop people from caring for patients. You can eliminate the people who would have been carried along by this system of hard work, but you can't stop the cream of the crop from putting their time in.
When you think about it, and I doubt if you have, what do you think your legacy will be?
Oh, I don't think I have much legacy. I'm glad to have. I've recruited some great people who work at our place. All of my people now are partners that I've recruited. I have the best division, I think, in the division of surgery of colorectal surgeons that I've been able to recruit. This is the
University of Pennsylvania.
University of Pennsylvania. So I'm proud of that. I'm proud of what I did when I was with you at Washington University. And I'm proud of the residents that I trained when I was at Thomas Jefferson University before coming to Penn. But I don't have a dominant legacy. I haven't invented an operation. I've cured some patients. I've lost some patients. But it's been a good time along the road.
What advice do you give, and would you like to see the young people get who are heading into surgery in general, medicine more general, and our specialty?
Well, I would advise them to do it. It's still the most honored profession. I was discouraged when I went to my medical school reunion class several years ago, and on the application that you sent in ahead of time saying what you were doing. Would I do this again? I absolutely would do this again. And but I was in a minority of the people, and a lot of the people who went into pathology or medicine, family practice, a lot of them said they might not do it again. A couple of surgeons in my class had already retired 5 years ago, and so what a waste this was of training for surgery, being able to do this, and then the system was such that they felt the climate was such that they no longer wanted to do this. The malpractice problem was such that they really had to pay so much for malpractice, practice defensive medicine. It became so unrewarding to them that they stopped doing that. And I'm hopeful that that's going to change over the next few years, and I think that the climate will change. I think government reforms will come around, that the tort problem will be relieved, and at some time we'll have no-fault insurance, and patients will be compensated fairly without attorneys getting a third of their compensation for bringing these frivolous lawsuits, and make our profession more enjoyable. But I would certainly encourage people to go into the field of medicine, but particularly to the field of surgery. I can't imagine a profession that's been more rewarding. So my advice would be for them to do it if they want to work hard. If they don't want to work hard, economics is the thing for you.
You've put a huge amount of your time and energy into the organizations of surgery, both the American Board of Surgery and the Colon and Rectal Surgery Society and Board. Tell me a little bit about what you think you've accomplished and why it's important to do that. I think a lot of people would shy away from bureaucracy.
Well, I don't look at it as bureaucracy so much. I don't know that I've accomplished so much. You know, you're in the fray. I mean, you make some decisions when you're there. If they're good, they hold up. If they're bad, the world hasn't ended. The next person coming along will change it. The arc of justice bends favorably over the period of time. I've enjoyed it. I think more people would do it if they had the opportunity. I was just lucky to have the opportunity to do it. I have been amazed that some people who had the chance to go on the board of surgery declined it because it was too much work. That's a thought that never entered my mind. I thought it was one of the highest honors of my life to be on the board of surgery, be on the board of colorectal surgery. And so I was a little bit amazed at people that I know that have had the opportunity who declined to do that. I've never looked upon that as being a burden. I would always do that again. You eat the cream of the crop are your friends when you're in those organizations. I mean, I can't imagine an organization that's been more fun than the ASCRS. Mm-hmm. And the American Board of Surgery was difficult, time-consuming. As you know, Ira, from being on the board, you're away from your office 31 days a month, 31 days a year. You're away from your office. You have to rely on your partners to cover for you from them. It's a financial burden to do that, but I would certainly do that again.
Bob, final words for someone who may be watching this years from now?
Well, if they're watching it years from now, if you have any sense, you've already turned off by now. You won't get to this final thing because it's been so boring you've turned off. But if you're so silly as to have stayed this long, I would just hope that if you're thinking about going into colorectal surgery, that you would do that. And I can't think of a profession that's been more rewarding, certainly for me.